The session. Just for your record, this meeting will be recorded. So just to let you guys know that I'm recording this meeting. And thank you everyone once again who have just joined now. So I'll just begin the session because it is 7:04 now. So, if you have attended my previous classes, you know that in the beginning I give a brief review about NAC, that what is NAC and what it looks like. But if someone is new to the session, please let me know. You can raise your hand or write in the chat box or unmute yourself. Then I can go through that. Otherwise, we can just skip those slides. So, is there anyone who's joining in for the first time? Please let me know. Okay, no one. Okay, that's good. So, as you all know that previously we have been discussing.
Sorry.
Sorry.
I the first time.
Okay, doctor. Thank you. So, we have a couple of new people. So, today's presentation is basically based on NAC oriented lab reviews, because sometimes in your NAC scenarios you do get lab results and you have to discuss them with the patient. So I'll be addressing that how we can do that effectively and efficiently with the patient. In the previous three classes, I discussed some counseling points related to GERD and related to urinary incontinence. I have posted the video of urinary incontinence on my YouTube channel as well, which you can see at your own ease at whatever time you are comfortable. So we'll begin with today's session. So this is NAC OSCE preparation boot camp, and a little bit of detail about me. So I am just an IMG like you guys. Sorry, I think I turned off my video. Okay. So I'm just an IMG like, what's going on? I don't know what's going on with the video today. Anyways, so I am just an IMG like you guys, and I started my journey of exams for Medical Council of Canada in 2021. Since then, it has been a bittersweet journey. But for the past 1 year, I have been working as a physician assistant with one of the family physicians here in Alberta, Calgary, Alberta. Other than that, I have some teaching experience from back home of teaching the undergraduate students. And apart from that, I'm a part of some of the volunteer organizations here in Calgary. So, 2 years back, I had this chance to represent the problems which are faced by IMGs to the health minister of Alberta, Mr. Jason Copings at that time. And I was a part of a delegation and I represented those problems. And that gave me the insight that I should be interacting with a broader audience in order to achieve our achieve our goals towards our license. So let's begin with today's session. Okay, so what is NAC? NAC is it is, as you all know, that it is a half-day examination, and it means National Assessment Collaboration. What do we mean by that? By that, we mean that all the students who are appearing on that particular day, Canada-wide, will be facing the same set of questions. So you do need to do something very differently in order to stand out. And my course is basically focused on this point, because I know that as IMGs, we really struggle with communication skills. We really, struggle with our soft skills. We might be very good with our bedside techniques, but we really struggle with the bedside manners. Therefore, the main emphasis of my course is that how I can, polish your communication skills and let you know how to present yourself in the examination. So as I mentioned, it's a half-day exam, and there are total of 12 stations, and 2 of them are pilot stations. That means that your performance on those stations will not count towards your final assessment. Now, the bad part of this, or the ironic part, is that you don't know that what those 2 stations are about. Therefore, or which one are those 2 stations. So you have to perform well on all these stations, apparently, okay, just to get a good score. And the time division in NAC OSCE is that you have a total of 11 minutes. You get 2 minutes outside the door, but I call that 1.5 minutes because 30 seconds are just wasted while running from one door to the other door. So you have 1.5 minutes. And in that 1.5 minutes, you have to decide your goal, that once you are entering the room, what are you supposed to do and how are you going to proceed and use those 8 minutes inside the room very effectively. So these 1.5 minutes outside the door, they will define your smooth journey inside the room. Because once you're inside the room, your timer is ticking, and you don't have time to readjust or rethink or reorganize your thought process. So this 1.5 minute outside the door is very, very important in order to organize your thought process. And there are a few tasks that we need to do in these 1.5 minutes. Number one, you have to make a list of your differential diagnosis depending upon the scenario which has been given to you. The scenario can be, just a vague scenario that you have this year old woman or child or whatever in the room, and address their concerns. Now, at this point, you're just lost. You don't know what to write as differential diagnosis. But if you know the basic history layout, and if you know a few points here and there that what you're looking for, you can make that template. So quickly just make your basic template, write your task that, okay, this question stem is asking me to do what. So just write that on your notebook so that when you're inside the room, you're focused. You know that, okay, this is not only a history station, it's a history and counseling, or it's a history and physical examination. So once you are inside the room, this will give you a clear view of your direction, that in which direction you need to proceed, and you will not miss that task, because it is very likely that you enter the room, you start asking the questions, you get confused over something, and you totally forget that, oh, you don't have time left for the physical examination. And the 8 minutes that are inside the room, you can just consider that maybe they're just 6 minutes inside the room, because it's not just you talking, it's the standardized patient as well who's responding back to you. So that back and forth communication, that will take some time. So whatever script you have prepared, you have to be very crisp about it. You should know that, what my questions are and what I need to do. You should be crystal clear about that. This is what NAC OSCE preparation should be about, more focused on these things, that how you can get through the station very smoothly, using your words appropriately according to the Canadian ethics and Canadian guidelines, and like the way you will behave with the patient in a normal life scenario. So as I mentioned earlier, that this is the time division, and in some of the stations you will have 3 minutes of post encounter. What is post encounter? That the examiner is going to ask you a couple of questions, and I have added a few today in my presentation as well, just to give you a flavor of that. Now, what the question stem can look like. Now, in my perspective or my view, I feel that typically the NAC OSCE question stems can look like either of these four things. Okay, it can either be a history station, it can be a history and physical exam, it can be physical exam only, which is very rare. Sometimes you might, get to examine cranial nerve. So for that, because it's a very long examination, you might have a whole station dedicated to that examination, but it is very, very unlikely. And it can be history and counseling. Now, the counseling part is very, very important. And why I emphasize more on that part? Because in my exam, I had 4 counseling stations. So you can well imagine that out of 10 stations, if you're having 4 counseling stations, that is counting towards 40% of your exam. And you need to perform really well on those stations. So counseling is something that I really want my students to, be good at. And that is what I will be focusing a lot in my boot camp as well, in the course that I'm offering for NAC OSCE. Okay, so we already, discussed this time division. Now, let's practice a scenario together, which is the agenda of the meeting for today. I have this question with me, and I have, I have described this question into 2 different forms. Today I will teach you that how you can tackle these questions in 2 different ways, and it can come in many different ways, for you to tackle. But I have taken 2 examples, and I will show you that how you can deal with this question and how to go through the station very smoothly. So now we have this practice scenario that you are a physician seeing a 65-year-old woman in a general practice clinic. She has been referred by her family doctor with the following lab results. Talk to her in the next 8 minutes. And you will have a copy of these lab results outside on the door, posted with the question. So these are the lab results. Would anyone of you volunteer, would like to volunteer and tell me that what do these lab results show? I can give you like 15 seconds for you to decide if someone wants to raise their hand or just open up your mic and tell me. Okay, no one? No one is brave enough?
Yes, yes, I
Okay,
can find it. Yeah,
uh,
thank you. It showed someone about the she has anemia, and
okay,
first I check hemoglobin, and
yeah.
as I said, I just said it 10, 24. Maybe first question I can ask about the medication she
Mm-hmm.
received. The I don't like something that, or and the source of anemia. What should have done for occlude blood she
Mm-hmm.
had or not. Then I want to consult with her. 2 points I concern about that. First, the source of anemia, what happened for her anemia, and
Mm-hmm.
how remove that, because the hemoglobin is up from 9 to 10. It
Mm-hmm.
showed me she is in medication. Maybe she received iron or something that.
Mhm. Okay. Okay. Yes, Mariam. That's very nice. Now, if you if you just have a look at this lab result. So if you go on the date section over here, we see that the patient was started the medication on the 10th month. Okay, first no, first of I think it's October. Yeah, 1st October 2024. Then the lab test was repeated in December. And then the lab test is repeated in March. Okay. So we can see the lab results at 3 months difference. But the rise in hemoglobin and hematocrit and MCV is there like 9, 9.5, 10, but it is not a very significant rise. And she is still anemic. Okay. So when you're outside the room and you are looking at this lab result, you should be making a list of things that you would like to do inside. As Maria mentioned that she would ask about the medication, of course, that what patient is taking. Plus, you have to quickly think that let me go back to the slide, that she is a 65-year-old, yeah, that she is a 65-year-old woman, okay, and she has been referred by her family doctor, and the lab results are such. So that means that something is going on, okay, and that what is going on, which is not letting her iron increase the way it should be. So a number of options that you will write on your notebook when you're outside the room. Number one, you will ask about the medications. She's 65. You will ask about her bowel habit. You have to make a list of differential diagnoses that can happen at this age. She's losing blood from somewhere. Why is she anemic? So all that list of differential diagnoses. And in my previous classes, I already discussed that how do we make that list of differential diagnoses. I will not be repeating that again, but I gave you a mnemonic of SPIT, that keeping spit in mind, this is how you are going to make a list of your extensive and comprehensive list of your differential diagnosis. So I'll not be going through that again today, but you make your list of differential diagnosis and you think about your agenda, that what are you going to do inside. So by looking at this scenario, and you have to talk to her in the next 8 minutes. So what do you think? Is it a history station only? Is it a history counseling station? Or is it a history and physical? What comes to your mind? So whatever you think this station is, for me, it's a history only station, probably, or maybe a little bit of counseling because I have to talk to the patient in this. Okay. So I will just write on my paper history plus minus counseling if I get the time, and I have to review the lab results with the patient. Okay, so now this is your task. Now you are clear that you are going inside the room and you have to ask these three things to the patient. And in the history, I will make a list of my differential diagnosis on one side, that I have to rule out this, and you cannot miss the life-threatening ones, as I mentioned in my previous classes. So now you enter the room and you have this lab result with you, and the patient is sitting right in front of you. This is the basic history layout. Uh, introduction, chief complaint, medical, family, social history, and wrap up. And this layout changes a little bit when we are dealing with a child or a teenager or a pregnant lady or an elderly. So we have to add and subtract a couple of things here and there. But this is the basic history layout. Okay, if you don't remember anything, just remember this thing that it is there. So this is the basic history layout. Now, how will you break the ice? That is that once you enter the room, how are you going to, develop that rapport with your patient? So you start by talking to the patient. Say, let's suppose her name is XYZ. So we'll say that, good morning, I'm Dr. Umar. I'm your physician for today. Can I please confirm your name and age? And the patient responds, yes, you can say I'm Julia. I'm 65 years old. Okay, Julia, nice to meet you. How would you like to be addressed? And she says, oh, you can call me Julia. Okay, Julia. So I understand that you are here to discuss your lab results. Is there anything else that you would like to, elaborate before I proceed further? And she can say, no, doctor, please continue. Okay. And then you tell her that I can see that your family physician has referred you to me. And I have this lab result which shows some iron deficiency anemia. So would you like me to discuss the report first? Or is it okay for you if I ask you some questions in order to have a better idea of your condition? So then go according to the patient's will. Patient might say, no, I want to discuss the labs first. Or she might say, oh, no, I'm fine. You can ask me the questions that you want. It can go either way. If the patient says, no, I want to discuss the labs first, so you take the labs first, okay? You take the labs in hand now. You take her lab report. If for example, if you're outside the room and you did not get enough time to go through the lab, sorry, I turned my camera off by mistake. So if you are outside the room and by any chance you did not get the time to look at the labs, it's perfectly fine. Just be confident in the room and just tell the patient, okay, can I have a minute to go through the labs again? She will be like, oh, yes, doctor, please take your time. And then you go through the labs again. Okay, now let me go back to the labs. So now you tell her, okay, so Julia, I have your lab results with me, and I can see that you were diagnosed with iron deficiency anemia on the 10th of 2024, and then you were probably started on some medication. But your follow-up for every 3 months still shows that you are still deficient and you are still not recovering that iron. So there can be a couple of reasons for that. I would like to ask some more questions in order to see that what's going on in there. But definitely there is something going on in the body which is not taking that iron that we are giving externally. So we need to figure out that, what is causing this iron loss from your body. So I will now proceed with some questions. Okay. So now you have quickly explained her that this is iron deficiency. To make it much better, you can just say that your hemoglobin on this date was 9, and I can see that this MCV, which is 70. So when it is under 80, we call it iron deficiency anemia. Okay, so all these things you can just explain. You can explain this lab report to her, and then you can tell her that I just want to see that the iron that we are giving you, it's not working for you anymore, and it is not increasing your iron levels the way we expect it to be. So let's go through a couple of things and see that what's going on in there. Okay, now she is 65-year-old. She is an elderly. So before you ask her anything else, you have to make sure that, being an elderly patient, she's being taken care of. That will be the first point that will give you extra bonus points rather than just jumping to your history, because the examiner will have the idea, oh, the doctor is very empathetic and careful. The doctor can, feel for the patient. And another advantage of going through elderly, screening and everything is that if it is a different, because in NAC OSCE, you can have something different as well. If it's a different station, for example, like a depression or elderly abuse station, the moment you will screen these questions, you will know that, no, it's not an elderly abuse station or something. It is just a simple iron deficiency anemia, and I have to deal with that. So you'll ask the patient that I can see that you will prescribe some oral iron. So are you compliant with your medication? She might say yes. She might say no. If she says, yeah, I'm compliant. Okay, how often do you take your medication? Doctor, I take 1 tablet every day. Okay, and who gives that medication to you? And she can say, oh, I can take it by myself. I'm very much independent, and I don't need to be dependent on anyone, and I can take it. Okay, that sounds good. How's your diet? What kind of food do you eat? Because she's an elderly, you have to, rule out that she's not alone. She's not on a tea and toast diet. So she can tell you, yeah, I take a lot of fiber in my diet and all that stuff. Okay. Now, the next thing is that usually we ask the occupation of the patient in the social history, but you can tailor your history inside the room according to the needs of the patient. So for this patient, I would like to know that is financially she is able to, get a hold of her medicines and pay for them. So I'll be asking her that I see, Julia, that you're 65 years old. So are you still working or are you retired? So she might say, oh, I'm retired. Okay. So you're retired. Okay, that's good to know. So how do you manage your finances? She can just say, oh, I have a very good pension plan, and I can manage my expenses very well. So you don't have any trouble in buying your medications? No, doctor, I don't have any trouble in buying the medications. Okay, thank you, Julia. I'm glad to know that you are compliant with the medication and you don't have any problems in buying that medication. You don't have any financial constraints as well. So now you have given the examiner this point that, okay, you are a caring physician and you have ruled out this thing. If the patient says that, no, doctor, I live with my, maybe my kids, or I'm dependent on someone or my spouse, or I've never worked in my life and I don't have the money, this will immediately turn into an elderly abuse station, and your set of questions will change entirely. But till this point, the patient is very clear that she is not being abused, she's financially independent, she's taking her medication. Then you proceed for the next step, and that is your history of presenting illness. So you will analyze her chief complaint. I have given a rough view of everything. Things are a bit more in detail when we're talking to the patient, but just to give you an idea that what are the things that we definitely need to rule out, they are that you will explain the lab work, okay, and ask your bleeding questions. Now, what are bleeding questions? In every set of system of NAC OSCE, there are some cluster of symptoms and there are some questions that we need to ask in that particular system. Then we can rule out that system, okay? So bleeding question is when a patient is coming to you with a suspected bleed, you have to rule out bleeding from any other part of the body, okay? And you have to rule out the impact of that bleeding. So you ask her, okay, so I can see that your iron levels are low. Is it the first time that you have been diagnosed with low iron, or did it happen in the past as well? So she will just say, no, no, this is the first time, okay? Then you can ask her, okay, so have you ever noticed bleeding from any part of the body? She might say yes, she might say no. You can say, how about when you brush your teeth? Do you see any bleeding from your gums? She would say no. Do you think you get bruised easily? Oh no, doctor, I don't get bruised easily. Okay. What about any, your menstrual cycle? When was your last menstrual cycle? Oh, it was maybe 20 years back, doctor, or 10 years back? I don't remember. Okay, did you ever had any vaginal bleeding after that? No, I never had. So you are ruling out all sources of bleeding, okay? Then you ask her, okay, Julia, I would like to know a little bit about your bowel habit. That how's your bowel habit? Are you having any troubles in your bowel habit? And she might say, oh yeah, I do feel bloated sometimes, and I think my bowel habit has changed. Okay, so have you ever seen any blood in your stools? No, no, doctor, no blood in stools. Have you ever seen dark colored stools or clay colored stools? No, doctor, I've never seen that. Or maybe I just didn't notice. I don't like to look at my poop. Okay, that's fine, Julia. That's very much understandable. So tell me more about your bowel habit. What changes have you noticed? So she might say, sometimes I get diarrhea, sometimes I get constipation. Then you can ask about the caliber of the stool. So what are you doing here? You are screening the patient for colon cancer. You're ruling out all those things because the patient is there with iron deficiency anemia, which is not improving with external medication, and it has been going on for a while. So now you know that this patient is having some chronic process going in the body. Why are you asking about your easy bruisability and all those stuff? Because you have to rule out other parts of the GI tract. You have to rule out liver and all that stuff. So this is a brief review of how you do that. Then first, now when you have established that this is something to do with the colon cancer, then you can ask her, okay, so do you have any family history of colon cancer? She might say yes, she might say no. Okay, you can ask her about other risk factors for the colon cancer, for example, her diet and her any medications that she's taking. You can ask about those blood thinners and things that they can just cause all that bleeding in the body. So this is a brief review of how we will do the history of presenting illness and analyze the chief complaint and ask the family history, her past medical history. And in social history, you still have to do that. So you just tell the patient that, Julia, since I have already discussed with you, you told me that you are retired and working fine. So there are certain other aspects of your social life that I would like to elaborate upon. So can you tell me that do you smoke cigarettes? No, doctor, I don't. Do you take alcohol? Yes, I do. I love alcohol. I take a lot of alcohol and all that. She can give you any history that she wants. So now you are done with your basic history and with explanation of the lab report. So this will be your 8 minutes encounter with the patient, considering the scenario that I mentioned earlier. After this 8 minutes, the buzzer rings, and then you can have a post encounter. And the examiner can ask you 3 questions. I have placed some of them in an example, and I will show you in the next slides. So, okay, just 1 second. I need to readjust this slide for a minute. Okay, sorry, I was just readjusting the slideshow. It was acting funny on my side. Okay, so yeah, so this is the examiner's checklist. Okay, it's a brief review. In my perspective, this is the examiner's checklist, what it looks like. So if you have ruled out symptoms of anemia like fatigue, dizziness, pallor, dyspnea, exertion, this is all that you will ask in the history, the impact of that anemia on the patient. GI malignancy symptoms, did you ask them like change in bowel habit, presence of blood in stools, melon, abdominal pain, unintentional weight loss? So these are all the history points. Red flags like fever, night sweats, appetite loss, then her past medical history, social history, medication history. And very important thing, because she's 65 years old, screening questions that have you ever been, diagnosed with any problems with your colon in the past? Did you ever have a fit test? Did you ever had a colonoscopy or sigmoidoscopy in the past? If she says yes, you have to ask her, okay, what was the result of that? Did you know the result? What was the result at that time? So be very vigilant. Whatever information the patient is giving you, throw another open-ended question to her. If she says, yes, I did have a colonoscopy 10 years back. Okay, what was the result of that colonoscopy? Can you recall the result? So, you might get your diagnosis right there. She might tell you that, yeah, I was diagnosed with some polyps and all that stuff. And then the next thing, which is very important, is general well-being. If you address the general well-being of the patient that you did in the beginning of the question, you ask her about her financial status, her finances, and everything else. Okay, so this is how you go through this examiner's checklist, and you can score good marks in all areas. There are certain special marks for communication skills as well. I have not included that in the list today. But though, because it's just a history station, it's not a counseling one. But if it's a counseling one, they also assess you on your communication skills and the way you're talking to the patient, your body language, your eye contact, and all that. Okay, so now there can be 3 minutes of post encounter. Okay, and what will be the post encounter probe can be? They can ask you what is your leading diagnosis. They can ask you what are your top 3 differential diagnoses. They can ask you what investigations would you like to have for this patient. What is your management plan? Okay, now all of us who are sitting right now over here or in the exam, all the students will be answering almost more or less the same answers for this. Everybody knows that the leading diagnosis would be a colon cancer. All of us know that, top 3 differentials, it can be this or anything else, whatever you are looking for. I don't know why my video is turning off again and again. Okay. Then what investigations would you order? So all the colonoscopy and everything. I'm so sorry. My video just keeps on turning off. I think the camera doesn't like me today. So anyways, So what investigations would you order? All of us will answer that, okay, we would like to go for a colonoscopy, urgent colonoscopy, okay? And then you'll say, I might go for a FIT if the patient did not have it in the past. You can say CBC, iron studies, peripheral smear, CT abdomen pelvis for staging of the malignancy. You know, all these answers, you can just tailor them according to your scenario. You can also tell your management plan that urgent colonoscopy, I will start the patient on iron supplementation. I will refer her to GI surgery and oncology and all those things. Now, what can give you some extra brownie points, okay? If you are a more vigilant doctor and if you have a very open mind, you will see that the patient is 65 years old. So you will say, I will also, if you miss this point in the history, that's fine. You can always include that in your management. So you can tell that, I would like to check the vaccination status of the patient. And considering that she's 65, I would like to know that if she is vaccinated for pneumococcal and her annual influenza vaccine. Now, this statement or this approach will give you some good extra points with the examiner. And you can also say that since my patient is 65, I would also like to know that if she has had a BMD done because she's due now for her bone mineral density according to the Canadian guidelines. Or you can just say she's due for her BMD. These 2 points, or if anything else that you can think out of the box, this will give you some extra brownie points. And this is how you will have those different set of marks as compared to other people around you, because everybody knows that it's a colon cancer, it's this, but the moment you see the age of the patient, you have to train your mind in this way that this patient is this year old, I have to start this with her, for her, even if the scenario is not about that. Don't include that in your history in order to save your time. But in your management plan, in the end, you can definitely say this. Okay. Okay. So this was one way of doing the scenario. Now, the same scenario can also show you like this, that you are a physician seeing a 65-year-old woman in a general practice clinic. She has been referred by her family doctor for unexplained iron deficiency anemia. Her blood work shows hemoglobin of 9, MCV of 70, ferritin of 8, and serum iron levels of 25. Take a focus history and perform a relevant physical examination. So now this station immediately turns into the, which one of this? What do you think it's now? What the station has turned into now? It is a history and physical examination now. Okay, so this means that now the station wants you to take a brief history and do a physical examination. They have already given us the lab and the interpretation of that lab result. They don't want you to talk to the patient about the lab reports. So you just see the lab reports, you know that it's iron deficiency anemia, you make your differential diagnosis, and you go inside the room and you talk with the patient and you take history and examination. So history points I have already discussed with you. Keeping in view the time constraints, I have not included a thorough examination in this class, but this is a brief stepwise physical examination for iron deficiency anemia, that you introduce yourself to the patient, you greet yourself, you start from the peripheral examination, and then you go to the relevant cardiovascular and abdominal examination. Okay, so this is how a stepwise approach is done. I have not included the detailed examination because it's something that you have to learn. And in my course, I will be giving slides about detailed examination. So right now, today, I'm just going through it quickly. But in the course, every system that needs an examination, you will get a detailed review of the notes. So this is, general examination, observe for general appearance, and then you give the closing statements. That what would be your closing statement? Now, for example, you have examined the patient. You see that the patient has conjunctival pallor. The patient is having, all the signs and symptoms of iron deficiency. And now the examiner asks you that, can you summarize whatever you saw, or can you give me a closing statement apart from those post and counter questions that I already mentioned? So the examiner might change those questions and ask you that, okay, what is your leading differential diagnosis? This, okay, can you give me a closing statement? Or you might need to explain the examination in a few words. So how will you proceed with that? So you can say that based on the physical examination, the findings are consistent with anemia. The patient exhibits pallor of the conjunctiva and mucous membranes, suggesting low hemoglobin levels. I did not observe any signs of jaundice, which makes hemolysis less likely. The cardiovascular examination revealed a normal heart rate without murmurs, and the respiratory examination was normal. Abdominal examination was unremarkable with no hepatosplenomegaly. Peripheral examination showed no clubbing, koilonychia or nail changes specific to iron deficiency, though pallor was present. Overall, these findings along with the lab values provided suggest a chronic process causing iron deficiency anemia, most consistent with potentially secondary to a GI cause. Further investigations, including a complete blood count, iron studies, and a potential colonoscopy, are warranted to confirm the underlying cause. So this is how you will close your station, so that the examiner has a very clear view that, okay, this doctor, this physician has examined the patient and is very well aware of, how to present the findings. So you can do this in post encounter if they ask, or you can just, when you're done with the station, you still have time. If the 8 minutes are not over, you can, give this closing statement. So this will give you a nice wrap up to your overall station. In either way, if you have done it as a history and physical exam, or you just discuss the lab reports and took a history, it will give you a nice ending to your presentation, or a nice ending to your station at that time. So this was all about today's interpretation. You can get other labs as well. You might get something related to vitamin B12. You might get, you can get some other, maybe an abnormal pap smear. So you can get all those things, but there are different ways to deal with all those situations. Okay, so now the NAC or OSCE course bootcamp that I'm providing, these are the details. I plan to start from next week. I'll be holding 2 batches, one on weekends and one on the weekday mornings. Timings would be 9:30 to 12:30 Calgary time on the weekdays, and on weekends it would be 11 to 2 in the morning Calgary time. And the fee for the entire course is 400 Canadian dollars. I plan to cover 140 to 160 high yield cases, and the number of students in each batch would not be more than 12, because I feel that that compromises the quality of preparation for the students. These would be the topics that I'll be covering in my course. As you can see, I have three GI classes, because GI is a big topic. Then cardio, resp, uro, neuro, MSK, endo, and peds, obs, gynae, and psychiatry. These are the topics that I'll be covering in each system, almost 15 topics from cardio. In respiratory, I have 7 topics. Then GI, I have 17 topics. Nephro-Uro, 7 topics. MSK, 11 topics. Neuro, 14 topics. Endo, I have 7 topics. Miscellaneous, there's a few topics from here and there, which are almost 10. Almost 12 topics from obs gynae. 16 from peds, and almost, I think they are 3, 5, 6, 7, there are 10 topics from psychiatry. Any questions and clarifications that you guys need till now, please feel free to ask me, and you can shoot me a message at medicinebyheart@gmail.com, and this is the link to my Telegram channel. So any questions, anything that you would like to comment on or share your views about, please go ahead.
Hi, Dr. San. I have a question.
Yes,
How many months does it take? I mean, it's 4 months. Exactly. Actually, we are preparing before May, right?
yeah, you're preparing from May, and it depends from individual to individual. If you are already done with QE1, or you have somewhat like you are in the examination system, or you are in touch with your studies for an hour of for a couple of years, 4 months are more than enough. But if you are a beginner and you are doing it for the first time, then I would say it might take up to 6 months, because it's just like learning your communication skills, and you're learning your script. So to be more confident, I think you might need 6 months. Yeah, but the course can be covered in 2 months. And after that, you have to do your individual practice, and you have to, relearn all the topics and make your reflexes in the time mode. So if you're already in touch with everything, 4 months are more than enough. But if you're already working in the system and you know how to interact with the patient and all that, but if you are new to everything, I think 6 months are required to go for the
And
exam.
your course takes every week has 6 hours, you said, or 3 hours per
No,
week.
it's 3 hours every
Oh,
week. I will start at 11. For example, if it's on the weekend, I'll start at 11 o'clock in the morning, and then we'll finish by 2. And in each systems, like some of the systems are spreaded along 2 classes, depending upon that what are the important topics. Yeah, but 3 hours class.
thank you so much. And is it repeated? Will be repeated or not?
Yes, I plan to repeat this then again maybe in March or April, but I think that March, April would be too close to the exam, and taking the whole course just 2 months before the exam is not a good idea because you will not get the time to revise anything. So I think that the people who are taking the exam in May, they should be taking the course like maximum till March. They should save some time for their individual practices because once you are done with everything, you need to practice the scenarios as much as you can.
Thank you so much.
You're welcome. Any other questions, comments, anything? You can also send me a message. Okay. So we don't have any questions, anything?
No, just thank you so much,
Thank
Dr.
you.
Sana. Thank you.
Thank you, Dr. Khan, for joining the session. Yeah, thank you once again. Okay, thank you very much, everyone, for joining. And I think we can call it a night. If there is a question in the chat box, just 1 second. Sorry, I don't know what's wrong with my camera today. I cannot see the question. Where is the question in the chat box? Just 1 second. Sorry. If someone can read the question to me, I don't know why I don't. Let me see the question. Do we need to learn normal lab values for NAC? No, 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 no. You don't need to learn any normal lab values for the NAC. It's almost everything is given with the lab results. Yes, even if it's a UTI picture or anything, they do give the normal values. Yeah. So you don't need to learn that with the NAC. Okay. So I think that was pretty much it. And thank you very much for everyone for joining the session today. And even my camera doesn't want me to continue, I think. Okay, thank you so much. Have a good night. And I'll see you guys soon. And a very happy new year to everyone.
Thank you. Have a good night.